progress.
Now welcome address by Dr. B. Saranya ma'am.
Good morning, one and all. On behalf of Department of Pathology, Annapurna Medical College and Hospital, it gives me an immense pleasure to deliver the welcome address. First of all, I wholeheartedly welcome the hero of this day, Professor Dr. Harsh Mohan, former Professor and Head Pathology, Government Medical College and Hospital, Chandigarh, Senior Consultant and Head, Dr. Gaur Path Labs, Haryana, who amidst his busy schedule accepted to share his knowledge and experience amongst us. I'm sure, sir, your guest lecture will enlighten us on the topic. Welcome you, sir. Next, I extend my sincere welcome to our Dean, Professor Dr. P. Shanmugam, sir, for this webinar. I would like to welcome our Controller of Examination, Professor Dr. P.M. Subramaniam, sir, for this webinar. I also extend my warm welcome to Professor Dr. Deepthi Shastri, ma'am, Dean, Vinayaka Missions, Kirupanandi Varyar Medical College, Salem. Welcome you, ma'am. I'd like to welcome our Medical Superintendent, Professor Dr. N. Mohan, sir, Vice Principal, Professor Dr. B. Usha, ma'am, Director Academics, Professor Dr. G. Dansegar, sir, Deputy Medical Superintendent, Professor Dr. Prasanna Babu, sir, for this webinar. Now, next, I extend my warm welcome to all the delegates, faculties and students from Annapurna Medical College and other colleges across Tamil Nadu and other states. Once again, I want to extend my hearty welcome to you one and all for this webinar. Please sit back and enjoy the webinar. Thank you.
Thank you, ma'am. Now I invite Professor Dr. B. Shanmugam, sir, Dean, Annapurna Medical College and Hospital, to share a few words.
Good morning to one and all. First of all, I thank our honorable chairman for giving us an opportunity to organize this webinar on amyloidosis. The speaker is a well-known professor and is a publisher. He has written a lot of books about pathology, and he has MCQ books also. He has written for PG and UG students preparation. So we are going to hear about this amyloidosis from his. I would like to throw a lot of lights on this. Even though we know the various causes of amyloidosis and its primary, secondary, and other things, we like to hear from you, sir. On behalf of the administration, I thank you very much for accepting our invitation by the Professor of Pathology, Dr. P.M. Subramaniam. Thank you very much, sir, for accepting our invitation and coming over here with us and sharing your ideas and your experience about the amyloidosis. Thank you very much, sir. And I sincerely thank our Department of Pathology, Professor P.M. Subramaniam, for organizing, frequently organizing the wonderful seminars and bringing up giants in the Department of Pathology for this webinar. During this period, COVID period, we are unable to conduct CMEs and physical lectures, but webinar is the only way of bringing teachers together and students and learning also. It is very useful. So I thank the Department of Pathology for organizing this webinar. I thank Professor Deepthi Shastri also is taking part in this webinar. Welcome you, madam, for this. I'm seeing a long time. Welcome you. I thank you for giving an opportunity. I don't want to take much of your time, so we will go for the subject. Thank you, sir.
Thank you so much, sir. Now I invite Professor Dr. P.M. Subramaniam, sir, Professor, Department of Pathology and Controller of Examinations, AMCH, to talk a few words.
Good morning to one and all assembled here, and good morning to the speaker of this day, Professor Dr. Harsh Mohan. Sir, we are all your fans. Every medical student, every pathologist, you are always with us in the form of a book. But the star of the pathology we want to see in the screen. I have seen you in many conferences. Many of our students have not seen you. So that is one of the purpose, and we want to hear the subject from you directly online. That is the purpose of this webinar. I don't want to take much of your time because your valuable words are anxiously expected to be heard throughout Tamil Nadu and other state pathology students also. So I hope definitely it will be a wonderful session and it will serve the purpose, sir. Thank you, sir. Sorry, Professor Harsh Mohan was about to leave USA in the next week, though he is in his busy schedule. For my request, he immediately accepted. I once again thank you very much for your kind acceptance, sir. Thank you, sir. Thank you very much, sir.
Now I invite Professor Dean from the Medical College and Hospital to share a few words.
Respected Dean, Annapurna Medical College and Hospital, Salem, Dr. P. Shanmugam, distinguished speaker of the day, Professor Dr. Harsh Mohan, respected Professor of Pathology and Controller of Examinations, Dr. P.M. Subramaniam, and all the other administrators, faculty members of Annapurna Medical College, and my dear students, good morning. I deem it a great privilege to be on the same platform or share the same platform as the doyen of pathology and the savior of millions of students across the country, Professor Dr. Harsh Mohan. Being an anatomist, I've always considered what Chaurasia is to anatomy, Harsh Mohan is to pathology. I once again feel honored to be able to listen to Dr. Harsh Mohan. I feel that the mark of a great teacher is not just to reach the slow learners, but also the advanced learners. And I'm sure all of us agree that Dr. Harsh Mohan achieves this feat effortlessly. I would like to congratulate the Department of Pathology for conducting this ECME and will be delighted to listen to Dr. Harsh Mohan deliver this guest lecture on amyloidosis and update. Wishing the speaker all the best and grand success to the Department of Pathology. Thank you.
Thank you so much, ma'am, for your kind words. Now I invite Professor Dr. N. Mohan, sir, Medical Superintendent, AMCH, to talk few words.
Good morning to all. Thanks for our honorable chairman and our dean and Dean VMKV, and then our Professor P.M. Subramaniam sir and Department of Pathology to arrange such a program today. Professor Dr. Harsh Mohan, he is a pioneer and he is a legend in pathology. He has done extensive research and written many books, as Madam told, for undergraduate and even for postgraduate, very useful one. And today he is presenting such a wonderful topic of amyloidosis, and he is sir, you are moved to our pathology community. So thanks one and all for participating in this nice event webinar. Thank you, sir. Thank you.
Thank you so much, sir. Now I invite Professor Dr. G. Dhanashekhar, sir, Director Academics, AMCH, to talk a few words.
Good morning, all. I congratulate the Pathology Department for this important webinar on amyloidosis. Professor Dr. Harsh Mohan doesn't need any introduction to the field of pathology. So we are very happy to be with us today, and thanks for the opportunity. Let us begin with the session. Thank you.
Thank you so much, sir. Now, introduction of the speaker by Professor Dr. K.M. Selvanayake, ma'am, Professor and Head of the Department of Pathology, AMCH.
Thank you for joining us for today's webinar. Today is a very important day for all of us because we have the legend of pathology. I'm honored and privileged to introduce Professor Dr. Harsh Mohan as a pioneering teacher in pathology. Professor Dr. Harsh Mohan, a renowned pathologist and an excellent teacher with more than 40 years of experience in diagnostics and academic pathology. He is a senior consultant and head histopathology cytology services at Dr. God Path Labs, Forest Hospital, Panchkula, Haryana. He is an alumnus and gold medalist of Pandit Bhagavad Dayal Sharma, Postgraduate Institute of Medical Sciences, Rohtak. And in the year 1992, under his dynamic leadership, Department of Pathology was established in PGIMS. He was professor and head of the Department of Pathology, Government Medical College and Hospital, Sector 32, Chandigarh, from 1994 to 2015. He has large number of publications, more than 300, in indexed in international and national scientific journals. He has had the honor of being invited as guest speaker in several conferences, CMEs, and webinars. He has authored several textbooks in pathology in various languages, including Slovak and Spanish, that have gone through multiple editions. He is a member of several academic bodies. He was honored and awarded by National Academy of Medical Sciences, Academy of Medicine Singapore, Union for International Cancer Control, and Indian College of Pathologists for his outstanding contribution in the field of pathology. He was president of IAPM in 2008 and editor-in-chief of IJPM from 2003 to 2007. He is a reviewer of various international and national journals and referee for National Book Trust, New Delhi, and Union for International Cancer Control, Geneva, for selection of fellowships and awards. He is an ICRE-TT-UICC Fellow, Holland, and ex-visiting professor of UMass US Aureus University, Aruba, Caribbean, and Colombo, Sri Lanka. He has been the recipient of several national and state awards and honors. Notable amongst them are Excellence in Teaching Award in 2008, Haryana Vigyan Ratna Award in 2010 and 11, and State Honor by Chandigarh Administration in 2015. Now, I'm pleased to invite Professor Dr. Harsh Mohan to deliver his talk on amyloidosis and update. Thank you.
Thank you, ma'am. Now we start the scientific session by Professor Dr. Harsh Mohan, sir. I invite Professor Dr. P. Shanmugam, sir, and Professor Dr. P.M. Subramaniam, sir, to chair the session. And I request everyone, if any queries or any questions are there, to please post them in the chat box, and it will be discussed at the end of the session. Thank you, sir, and we start the scientific session.
Good morning, everybody, dignitaries in the host institution and the whole lot of delegates who are there to attend this seminar and webinar. There is going to be a slide seminar and there's going to be a talk in the form of a webinar for the next about 80 to 90 minutes. I am delighted to be with you through this forum on a working day that you have spared your time to be attending this, and it's an honor to be with you all. The major advantage of or side effect of the COVID is that it has brought us closer across the cities without having to travel. And that's what I take as the positive outcome of the COVID in the last about 2 years, that we are able to talk to each other through this forum without having to travel. Thank you so much, Professor Subramaniam, for making this possible. And I'll try to do justice to the topics which have been selected by your team. I had given a list of topics to Professor Subramaniam, and they chose this topic of amyloidosis, and Professor Subramaniam wanted me to present a few interesting cases in the form of slide seminar as well. Now, these two talks will be largely, the target users will be somewhat different, although postgraduates would also find this webinar on amyloidosis but is largely targeted at undergraduates, right? Slide seminar is largely targeted at postgraduates, but undergraduates may also find, or some undergraduates may also find that somewhat useful for what will come to them in coming years. So first will be the webinar on amyloidosis. Now, this is a talk which I have prepared from my either own resources or consulted some other academic resources from internet and other books. And this is only being used for teaching purpose, not any commercial use. And there is therefore no disclosure regarding any financial interest or conflict of interest or infringement of property works of others. If I have included work of others, that has been acknowledged and referenced. Now, people of my era who were undergraduates some 50 years back, they had read that famous textbook of pathology, which was by William Boyd. It used to be called Pathology, Structure and Function in Disease by William Boyd, who was a master teacher, and that book lasted for good about 5 decades through 2 generations of students all over the world. We read this book, and at that time, the amyloid was considered as a kind of degeneration or infiltration, and was therefore term amyloidosis was coined for the condition, which was first described by Rokitansky, but later was renamed by Burko as amyloid, meaning thereby that it is starch-like. Amylin is starch-like. And that was the property of starch staining with iodine, which gives it a mahogany brown color. And therefore, Burko and his workers felt that it could be a starch. Later, it came out to be that it is a protein or a glycoprotein. And the other thing which was known 50 years back, which is remarkable, even at that time it was known that remissions occur in some cases of secondary amyloidosis when the predisposing condition is treated, and the amyloid material is then reabsorbed. But the primary amyloidosis, even 50 years back, was known that it has a bad prognosis than the primary amyloidosis. Look at the extent of knowledge. This concept, even now we hold, that secondary amyloidosis can be better cured by treating the underlying condition than the primary amyloidosis. But in the last 50 years, what all has developed is a whole lot of proteins and protein structures, which the amyloid comprises. Now we know that there are close to about 35 or 36 proteins which comprise these amyloid, not starch anymore. And we also know how to type the amyloid of different types based on the protein, and accordingly, the treatment can be directed at reducing the precursor protein which comprises that form of the amyloid. So there are very interesting review articles in recent times. I have selected 2 of them, like an organ system-based approach to differential diagnosis of amyloid type in surgical pathology, which is by identification of the protein component which comprises the amyloid. And another one is on classification of amyloid, another review, which has appeared in Hematologica, Acta Hematologica, and the other one is in Archives of Lab Medicine. Now, I have divided my talk into 2 divisions. One is the basic concept, and other is the newer aspects which have come into our learning of amyloidosis. The basic concept is a review of what we all generally would know during undergraduate years, that amyloid is not a single disease, but amyloidosis is a group of disorders which have different etiology. And this material called amyloid is an extracellular deposition of the material, and the proteins which comprise this material are insoluble. And they have some common staining properties. And one of the most important property is, of course, the congophilia, as we shall talk of. But then ultrastructurally, all forms of amyloid are similar as regards their physical appearance is concerned, which means the ultrastructure or electron microscopic appearance is concerned. But their protein composition is different. So therefore, biochemical composition of different forms of amyloid is variable. And the other thing which we know is that in the current concept, we know that amyloid occurs because of misfolded protein. So it's a protein folding disorder, as we shall talk of how in the endoplasmic reticulum protein folding disorder occurs. So these are some of those concepts which have come in our knowledge. Now, the disease is quite progressive and results in compression of the parenchymal cells and therefore causes dysfunction of the organ, and therefore organ failure will occur. One of the most important organ failure is the renal failure, that is the kidney involvement. The other is the involvement of heart. Of course, it involves many organs, and that's why many forms of amyloidosis are systemic in distribution. So ultimately, it progresses over a period of time and results in organ failure or multi-organ failure. And that results in devastating consequences and destruction of tissue, which results in organ failure, and then death can occur. The most common causes of death being renal failure in 20% of cases, and arrhythmias or cardiac failure in another proportion of cases because of amyloid. Now, some recent advances have taken place in management we shall talk of, which is for early diagnosis and correct typing, and therefore reduction in the protein which comprises that particular type of amyloid. Traditionally, we know that morphology is the gold standard for identification of amyloid. Grossly, there are some certain features. Microscopically, there are more important features. Grossly, an affected organ on autopsy will show enlargement generally, and the appearances of a firm organ, which is pale and waxy, translucent in consistency, and on routine staining with hematoxylin and eosin, the amyloid appears as pink, glassy, acellular, amorphous, or eosinophilic extracellular material, more commonly located in the basement membranes of the vessels. One of the most important stain which is employed besides suspecting amyloid on H&E is to apply the Congo red stain. And then if it shows congophilia or it shows pink, rose pink color, then you visualize that rose pink color under the polarizing microscope. And by using a polarizer and analyzer and adjusting the fine adjustment of the microscope, you can see apple green birefringence, which means that those fibrils will shine in one focus, and by movement of that fine focus to another focus will show birefringence, which means they fluoresce or shine in the polarizing light. Just quick review of some of the commonly affected organs in amyloid. For example, amyloid of the kidney gives rise to enlargement, often bilateral enlargement of pale, waxy appearance with loss of corticomedullary distinction in the kidney. And on microscopy, most common location of deposition of amyloid are in the glomeruli, which initially begin in the glomerular tuft in the capillary basement membrane, but subsequently they replace the entire tuft. The lumen is obliterated, the lumen is obliterated and replaced with this homogeneous eosinophilic material with sparse nuclei, which are present here, are of residual endothelial cells. So there is massive deposition of amyloid in the glomerular tuft in this section. So is the case here. Besides glomeruli, the amyloid deposits can also occur in the tubules, especially in the basement membrane, not seen in this field, and can also occur in the interstitial blood vessels in the basement membrane. The conformation is by congophilia, which will show corresponding areas which were seen homogeneous pink eosinophilic material in the H&E staining to show the rose pinkish coloration in those areas. And these areas, when seen under polarizing light, will show this kind of birefringence, which means shining appearance of two fields in fine adjustment when you can see this kind of birefringence, which is called apple green birefringence after congophilia. Spleen is another organ which is involved commonly in systemic amyloidosis, which can have sago-spleen appearance or the lardaceous appearance, lardaceous spleen appearance. The sago spleen is in the form of sago grain-like appearance, where you can see the whitish colored arterioles of the white pulp surrounded by the parenchyma of the spleen, while lardaceous is homogeneous map-like appearance of pale waxy replacement of the red pulp area, while here it is generally around the white pulp area where there is a central arteriole surrounded by the amyloid. In lardaceous, it's mainly in the red pulp area, and the splenomegaly is much more in lardaceous spleen than in the sago spleen. Microscopically, it may show mixed picture or it may show characteristic of sago or lardaceous amyloidosis. Here you find the homogeneous pink color present all throughout the red pulp zone. This is the atrophied white pulp where you can see the central arteriole, but there is hardly any amyloid here. So there's a lardaceous amyloid deposited in the red pulp zone, which shows this congophilia and the corresponding. It's not corresponding. Here it is present in both the red pulp as well as in the white pulp area, where you can see the apple green birefringence in red pulp as well as the white pulp zone, that is the blood vessel, also showing the amyloid in the central arteriole of the white pulp. Liver is also involved in systemic amyloid in about 5 to 10% of cases, and the deposition occurs in the space of Disse, which separates the cords of hepatocytes from the sinusoidal lining cells, and it gives rise to hepatomegaly, which has homogeneous pale waxy appearance, and microscopic, the presence of homogeneous eosinophilic material causing atrophy of the cords of hepatocytes. The residual nuclei are of the atrophied hepatocytes, while most of this pink material is all because of amyloid deposition in the atrophied hepatic lobule. And on congophilia with the polarizing microscopy, the same pink will show apple green birefringence. Heart is involved in primary amyloidosis more commonly than in secondary amyloidosis, and it can have a diffuse involvement or nodular involvement in the chamber of the heart, when it can give rise to what we call as restrictive cardiomyopathy. When the amyloid deposits in the myocardium are extensive, it gives rise to restrictive cardiomyopathy. The deposit of amyloid is between the myocardial fibers, that is the interstitium, which causes atrophy of the myocardial cells and replacement by the amyloid. So the myocardium is atrophied and replaced by abundant deposits of amyloid in the interstitium of myocardium, and that impairs the function of the heart, which can give rise to cardiac arrhythmias or heart failure or even death. And the similar kind of apple green birefringence as seen in polarizing light after congophilia, congo red staining. Then the amyloid is also seen in certain endocrine lesions, like here, medullary carcinoma of the thyroid, arising from parafollicular C cells, where you find homogeneous pink material deposited as amyloid, which can be stained both with congo red as well as a specific antibody stain, like calcitonin antibody stain can be done, which gives positive brown color in the amyloid containing area. And you can do the congophilia as well as the apple green birefringence in medullary carcinoma of the thyroid as well. Another condition where you can have amyloid deposition around the vessels as well as around the neurites is the Alzheimer's disease, where you find the cerebral amyloid angiopathy as well as the neurite plaques, where you have these pink globular structures, which can be confirmed by antibody stains as well as by congruent staining. So congruent staining will show presence of cerebral amyloid angiopathy, congruent followed by apple green birefringence. And this is what you find in antibody stain, where you find the presence of the brown color with amyloid beta antibody stain. And likewise, you can have the neurites or neurofibrillary tangles, which will show positive staining with this antibody, which comprises this protein, that is amyloid beta antibody stain. And rarely you may find lichen amyloidosis, where globular amyloid deposits are seen in the papillary dermis, where you find that reed pegs are separated by these globular deposits of pink amyloid material, which can again be stained with congruent stain and will show positively. One of the quick way of making diagnosis of amyloid, systemic amyloidosis, is by doing abdominal fat biopsy or aspiration, fine needle aspiration. And this biopsy will show presence of this homogeneous pink material, both around the nerves as well as around the vessels or separating the adipocytes. And this will show the positive staining with congruent followed by the apple green birefringence is an easy way of making the diagnosis. So that's about the morphology of amyloid, which is generally uniform in most of the organs. That this is extracellular. On H&E it shows pink homogeneous material, and congophilia is positive, and apple green birefringence are some of the general features to sum up the morphologic characteristics. Then the physical features of amyloid are uniform regardless of the underlying proteins, and ultrastructurally amyloid shows fibrillar structure, and the fibrils are composed of 7 to 10 nanometer diameter tiny fibrils, which are wound with each other, separating a clear space so that they form a what we call as a beta plated sheet configuration. And that's why amyloid is also called as beta fibrillosis, because this is wound as the fibrils in a plate-like fashion. And those fibrils have Congo red binding sites, which give the positive staining, which then by apple green, polarizing light will show apple green birefringence. So this is what I meant by the fibrils, which are of indefinite length and 7 to 10 nanometer in thickness, and they're separated by space, and that space is the place where Congo binding sites are present. And then in between, there are non-fibrillar component, which we call as P component or pentagonal shape or donut shaped structures, which are present separating these fibrillar protein called as P component. And on ultrastructure, this is a diagrammatic representation. If you look at actual EM picture, electron microscopy picture, you find these fibrils of indefinite length, where you find gray color, and they are separated by some space where congruent stain will take up. And then these are donut shaped. The dark gray colored structures are the donut shaped P components. And this is another diagrammatic appearance, how the fibrils are wound onto each other in a plated fashion, and there is a space, and they are congruent binding sites, and there is pentagonal or P-shape, P component, non-fibrillar component, and this is where the amyloid protein binds to the congruent stain. And on fluorescence microscopy, you find the P component will show donut-shaped appearance in the fibrillar proteins, which can be visualized. All forms of biochemically heterogeneous amyloid all have got P component present in them. Regardless of the type of fibrillar protein, all forms have P component in them. So therefore, it comes handy for confirmation of the amyloid, but can't be used for typing the amyloid. Little more detail on biochemical composition of the amyloid, that there is a fibrillar component and there is non-fibrillar component. Fibrillar component in the form of proteins and is the larger component, comprising more than 95% of the amyloid material. Most common are the amyloid light chain or AL proteins, fibril protein, and AA fibril protein, and then there are several other fibril proteins. The non-fibrillar components, which comprise less than 5%, is dominated by P component, but then there are others as well, like apolipoprotein and a few other less common types. Now, talking about each one of these briefly, AL fibril proteins are the immunoglobulin light chain derived protein. They may be in the form of whole or light chain or a part of it, which may be in the form of a minor terminal or a part of the C region. Now, therefore, a part of that light chain may be in the form of a lambda or a kappa light chain. Lambda is far more common than kappa, but in a given case of amyloid, there is monoclonality or homology. This amyloid in a particular case will either be of a lambda type or a kappa type. Lambda is far more common than kappa type. Rarely, you may find heavy chain immunoglobulins also in the amyloid fibril protein. Then are the other form of amyloid fibril protein, which are called as AA fibril protein. Now, AA fibril protein or amyloid associated proteins are derived from a precursor serum protein called as serum amyloid A protein. That's called SAA. And this SAA, circulates in blood along with HDL3. Now, AA deposits, unlike AL deposits, do not have a sequenced homology. And SAA is synthesized in the liver just as other acute phase reactant proteins and is the form of protein which is synthesized excessively by the liver in response to certain chronic infections or chronic destructive conditions. Now, chronic infections can be variety of bacterial or suppurative infections, or there can be some other destructive conditions like autoimmune diseases or neoplastic diseases. So all of them result in excessive synthesis of the precursor protein SAA, and those are the conditions which are associated with AA fibril protein form of the amyloid. Then there are other forms of amyloid fibril proteins. Sorry. These include transthyretin as one of the more common out of these fibril proteins. And this transthyretin is derived from transthyretin. This is a form of transport protein. That's why it is called trans. And it transports two proteins, that is the thyroxine and the retinol. That's why it is called, this transport protein is called as transthyretin because it transports thyroxine and retinol. Now, mutation of this protein by a substitution results in excessive deposition of transthyretin, and there are several forms of mutations which are known, and there are more than 60 types of mutations which are known for transthyretin formation. Then there is amyloid beta 2 microglobulin, abbreviated as A beta 2M. Now, amyloid 2 beta microglobulin is formed from a precursor protein called as beta 2 microglobulin, which is a part of the major histocompatibility complex. So A beta 2 microglobulin is another form of amyloid fibril protein. Then another one, not to be confused with amyloid beta 2 or A beta 2, is beta peptide. Now, this beta peptide, called as amyloid beta peptide, A beta is the abbreviation, is derived from precursor protein called as A beta precursor protein or A beta PP. Now, this A beta protein, the type which is seen in Alzheimer's disease and other cerebral form of the amyloid, has got the transmembranous cleavage sites at 3 places in the form of certain enzymes like secretase alpha, beta, and gamma. The beta and gamma are more common than alpha. Then there are the fibril proteins which are seen in endocrine amyloid. Those include the precursor amyloid proteins like calcitonin, seen in the medullary carcinoma of the thyroid called as amyloid of calcitonin or ACAL, and likewise amylin or islet cell tumor amyloid. The amyloid associated with diabetes called as amyloid from insulin, and likewise prolactin amyloid in pituitary tumors. And amyloid of prion proteins or priinosis is another form of fibrillar protein derived from a precursor protein called as prion precursor protein or PRPP, which is seen in a few forms of cerebral amyloid like Creutzfeldt-Jakob disease, mad cow disease, and other cerebral diseases. Then are the minor component besides fibrillar component are the non-fibrillar component, which include largely amyloid P component and some other components. The amyloid P component, as I showed you in the physical characteristics, is in the form of donut-shaped structure. And this is again a protein which is synthesized in the liver. It's related to C-reactive protein, but is structurally not exactly similar to CRP. It is different from that. And as I said earlier, P component is present in all forms of amyloid, regardless of the underlying fibrillar protein. Now, this is also derived from a circulating serum amyloid P component, which is a glycoprotein derived from the serum alpha-1 glycoprotein, which is a acute phase reactant protein, and it is derived from that itself. That is APR, or acute phase reactant protein, is the precursor protein from which it is derived. The other non-fibrillar component is a apolipoprotein, abbreviated as ApoE. This is a regulator of lipoprotein metabolism and is again found in most forms of the amyloid. And one particular component of apolipoprotein called as ApoE4 is found to have increased risk of the protein deposition, the amyloid protein deposition in Alzheimer's disease. Now, besides amyloid P and apolipoproteins, some of the glycosaminoglycans, particularly heparan sulfates, are also deposited in the amyloid as non-fibrillar component. Now, amyloid is characterized by a variety of features, and accordingly, its classification has undergone several modifications, like primary and secondary, or associated with underlying diseases, or localized and systemic, or association depending upon the underlying proteins. But currently, accepted classification, which is clinical pathology classification, is dividing the amyloid into the systemic amyloid and localized amyloid. Systemic means generalized amyloid, and localized is organ-related amyloid. Now, systemic amyloid obviously is more common and is dominated by two major forms of amyloid, that is the primary and secondary reactive, that is primary systemic amyloid and secondary systemic amyloid. Secondary is also called reactive amyloid. The primary amyloid is largely seen in a whole lot of plasma cell dyscrasias or plasmacytosis, and is comprised by amyloid light chain form of the fibrillar protein, and its distribution is in heart, bowel, skin, nerves, and kidney are the dominant organs. While secondary or reactive amyloid, the underlying fibrillar protein in these is AA type of amyloid protein, and is seen in chronic infections, chronic inflammatory conditions, which mean a whole lot of autoimmune conditions, and many advanced cancers, which are related with metastasis or disseminated cancers causing destruction of tissue. And the secondary amyloid, which is more common, is seen in systemic distribution in solid organs like liver, spleen, kidney, adrenal. There are some of those sites. Then there are other forms of systemic amyloid like hemodialysis associated amyloid, comprised by amyloid beta 2 microglobulin, and seen in chronic renal failure who are on hemodialysis for long term, and the deposits are mainly in the periarticular tissues, although deposits may be seen in other systemic organs as well. And heredofamilial form of the amyloid, which occurs in certain geographic locations like hereditary polyneuropathy, where the underlying protein is ATTR and is seen in peripheral nerves and heart besides other organs, but dominantly in the heart and peripheral nerves. Familial Mediterranean fever having particular geographic distribution in areas around the Mediterranean region. The type of underlying protein is AA form and has got the same kind of distribution as the other form of AA amyloid. So the difference is that this is familial and has got specific geographic location. Otherwise, the underlying protein and the organ distribution is similar to the secondary form of amyloid. And then there are some rarer hereditary form of amyloid which have systemic distribution. Then there is localized form of amyloid, which is senile cardiac, which is transthyretin form of the amyloid, ATTR, localized largely to heart. Cerebral amyloid, where the underlying amyloid may be amyloid beta protein or amyloid of the prion proteins, and its distribution is in the cerebral vessels, the plaques or neurofibrillary tangles, and is seen in Alzheimer's disease and encephalopathy, whether Creutzfeldt-Jakob disease and mad cow disease. Then endocrine amyloid is another form of localized amyloid seen in certain conditions, and accordingly, the underlying protein is distinctive, like medullary carcinoma of the thyroid. The underlying protein is precalcitonin, and proinsulin as the underlying protein in diabetes mellitus for a long time. And this distribution is in the islets of Langerhans. And likewise, the tumor-forming amyloid, which are rare form of localized amyloid nodules in certain organs like lungs, larynx, skin, urinary bladder, tongue, and eye. The amyloid protein is AL and is seen in corresponding anatomic locations as rare form. Now, primary and secondary are the dominant forms of the amyloid and can be distinguished by their distribution, organ distribution, underlying protein, their pathogenesis, their incidence, which is important, that primary amyloid is more common in developed world like US and European countries, while secondary amyloidosis is more common in developing and the underdeveloped countries, where infections are still a major problem and containment of infection is not instituted timely, and therefore that results in chronicity of the infection. And therefore, secondary amyloid is more common in developing and underdeveloped countries than in the countries where longevity is associated with higher incidence of primary amyloid or AL form of the amyloid. The other thing is that secondary amyloid can occur at any age, including in children. The primary amyloid occurs in elderly or middle-aged people. The prognosis, as we have discussed already, is much worse in primary compared to secondary, and it is possible to distinguish the two sometimes on the basis of congruent staining itself by permanganate treatment. The primary amyloid persists after permanganate treatment, while secondary is solubilized after permanganate treatment when seen under light microscopy and congophilia. Now, besides AA and AL form of amyloid, these are other forms of systemic amyloid like hemodialysis associated amyloid, the patients who have been on dialysis for a long time and are associated with this form of fibrillar protein called as A-beta-2 microglobulin, and the deposits are in the peri-articular locations, while heredofamiliar form of amyloid is associated with ATTR form of the protein and is seen in certain specific conditions like polyneuropathy or in Mediterranean fever, where the type of protein is AA, and then the less common form where the specific proteins are deposited. Those are heredofamilial. We've just now discussed the classification. And the localized form of amyloid like cardiac, cerebral, and the localized form of amyloid, endocrine amyloids, which we just now talked of. Then we briefly talk about how amyloidosis occurs. Now, it's been known for more than 80 years that amyloid could be induced in animals by repeated injections for production of the toxide for the synthesis of the anti-toxide serum or ATS. When the animals were repeatedly challenged with the antigens, the antibody formation was synthesized, but at the same time, these animals developed toxide. So therefore, it was established that it has immunologic pathogenesis some 80 years back, but more and more information has come in the last 70 to 80 years. Now we know that amyloidosis occurs because of an excessive pool of the precursor proteins. That means the precursor proteins which comprise that particular form of the amyloid are elevated in the blood. So that would mean that AL form of the amyloid will be elevated. AL form of the protein will be elevated in plasma cell dyscrasias like multiple myeloma, or even heavy chain diseases like Waldenström macroglobulinemia can be associated, or the chronic infections or destructive conditions which have elevated SAA precursor protein, and likewise other precursor proteins which are elevated, whether prime proteins or beta-2 microglobulin or A beta proteins. Second is that this is a protein fibril misfolding and aggregation disorder, that there is a reversible misfolding and aggregation is what happens, which means the normal process of the folding and degradation is hampered, and instead the misfolded proteins are passed on to the blood rather than being degraded. So there is excess of precursor protein, and there is reduced or limited proteolysis of those proteins which are misfolded. Normally those misfolded proteins are eliminated because of degradation, but here there is a partial degradation. So that results in aggregation of those misfolded proteins in the blood, and that they get deposited. And then into those fibrillar protein, some non-fibrillar components which are elevated in the blood are deposited, like P component or apolipoprotein. So this is what happens. There's an excessive pool of precursor proteins, and there is a misfolding and aggregation which are partly degraded, and those which are not degraded are passed on to the blood, to which the P component and other non-fibrillar component get integrated and result in insoluble proteins which are in the form of amyloid. So accordingly, in primary amyloid, it will be AL fibrillar protein, which will result in this partial proteolysis and eventually resulted in formation of amyloid at specific organ sites. And likewise in chronic infective, inflammatory, autoimmune or disseminated cancers, there you will find that there is deposition of those proteins which are not degraded, and therefore they get deposited with the aggregation of other proteins into them. And similarly, other forms of fibrillar protein, which results in specific form of the amyloid proteins. Then what is new about amyloid now? Now we understand that that amyloid is a misfolding disorder, and therefore the treatment is directed at elimination of the supply of that amyloidogenic protein, which is elevated and misfolding. So the treatment is targeted at two things. One is reduce the precursor protein, and second is avoid that misfolded protein being passed on to the blood so that they get degraded. That's what is the current line of research and therapeutic intervention. So management of systemic amyloid requires radical approach, because kidneys are most often affected. In fact, 20% of cases of systemic amyloid suffer from renal failure, and they become the cause of death in these cases. So novel therapeutic strategies are directed at, therefore, aggressive chemotherapy to reduce this protein, and the other is organ transplant, or the therapy directed at systemic amyloid to reduce the amyloidogenic protein, or to avoid that misfolded protein being passed on. Now, this is what happens normally, that from rough endoplasmic reticulum, the proteins which are normally correctly folded are passed on through the vesicle into the Golgi apparatus. So this is a endomembrane system where there is a Golgi apparatus, lysosome, and endoplasmic reticulum, which are interconnected to each other for transport. So the transportation takes place through that endomembrane system. Now, what happens in amyloid is that these misfolded proteins, which should normally be degraded by ubiquitin protease system, and the proteins get degraded, here they fail to get degraded. So therefore, these misfolded proteins pass on to the blood and get deposited. So the diagnosis of amyloid, first of all, is for detection or presence or absence of the amyloid. And that is best done by tissue biopsy or FNAC. Because there is no diagnostic biochemical marker or a body fluid marker on the basis of which definite diagnosis of amyloid can be made. So it's only the tissue material which is provided to the pathologist, which results in the diagnosis. So the gold standard is therefore congruent staining, and it's important to interpret it correctly. It's not only the congruent staining, look at the correct color and the polarizing microscopy and looking at the proper color of the birefringence and not looking at anything else like fibrin or some material like collagen, which can also have misinterpretation. So it's important to see it and interpret it correctly. Besides congruent staining, few other stains and techniques which have come into the armamentarium of pathologists are the fluorescence staining, especially the thioflavin T and to some extent thioflavin S. Then metachromatic stains have been applied in some labs like roselyn dye, the crystal violet and methyl violet. These are some of those old stains like Elchin blue and PS, which are quite less specific. And the biopsy site is chosen depending upon the organ of involvement. If kidney biopsy, if kidney is involved, then kidney biopsy is most preferred. If a systemic amyloidosis is suspected, then one of the common sites which are biopsies is abdominal fat or subcutaneous fat aspirate or a biopsy or an affected organ biopsy. Currently, we know that there are more than 30 amyloid-related proteins which are identified. Some of them are quite uncommon, but 5 of the most common type, of course, are the light chain amyloid, that is the lambda and kappa chain amyloid, transthyretin, serum amyloid A. These are all, mind you, Western studies. Serum amyloid A 6% and beta-2 microglobulin is seen in hemodialysis cases, and leukocyte chemotactic factor, or elect, is seen in about 1 to 4%, which is a newer form of the protein which has been identified in renal amyloidosis. But these studies are Western. We know that the secondary amyloid and therefore SA is most common form in the developing countries, and in Western countries, this is the form which is most common. The typing, first is detection of the amyloid. Second is the typing of amyloid. The typing is done by the immunohistochemistry for specific form of protein. Now, one of the general immunohistochemical stain which is applied for confirmation of the amyloid is the amyloid P protein antibody stain, that is AP antibody stain. That is universal. That's present in all forms of amyloid. But then to type the amyloid further, so AP can be used for confirmation, but to type the amyloid further, these specific antibody stains, immunostains are applied. Like for AL form of the amyloid, you apply, kappa and lambda chain immunostain, and likewise you apply the AA antibody stains, and similarly hereditary form and several other protein various antibody stains. Obviously, most labs don't have all those antibody stains, and they are sent to referral labs. Barring kappa and lambda, most labs won't have. Amyloid P component is another one which would be readily available. The other thing which is important is, while interpreting immunohistochemistry, immunohistochemical stain, is to correlate the congruent positive area to the immunohistochemical positive area. That's a brown colored positive area should be correlated with the congruent positive area and not misinterpreted as a false brown color at some place. So for a cleaner background, the researchers have recommended frozen section immunofluorescence, but that can be done only if a prior information of or prior knowledge is available that a frozen section for this staining will be done. This is just to show you the kappa and lambda light chain immunohistochemical stain, which can be done in a light chain. Immunofluorescence stain can be done in the hair. It is done in kidney, where, and this one is a P component, which is positive. Now, a paper has come in recent times where an integration of the immunohistochemistry with the in situ congruent staining has been done. And this combination of the congruent staining with immunohistochemistry has found to be useful as per this study. This allows actually focusing of the fluorescent congruent positive areas while evaluating immunohistochemistry, thus avoiding signing out false positives. So therefore, there are researchers who have done both these stains in the same case itself. A group of workers have also devised a scoring system of the extent of involvement of amyloid in kidney. And therefore, they have come up with the scoring and grading system of renal amyloidosis, where minimum amyloid deposition as grade 1 amyloid, or mesangial deposition as grade 2, focal mesangiocapillary deposition as grade 3, diffuse mesangiocapillary as grade 4, membranous amyloid deposition as grade 5, and advanced renal amyloidosis as grade 6 is how they have graded them. And nowadays, genetic testing is also available to know the family studies where one individual is found to have amyloidosis, that other family members are vulnerable to develop that or not. So molecular characterization of amyloid protein, and this can be used complementary to other diagnostic techniques as well. And finally, this is an image from Harrison's Principles of Internal Medicine, how to make the diagnosis and typing of the amyloid. Gold standard remains the tissue biopsy, and the non-invasive other blood tests are supportive but not confirmatory. And tissue biopsy, which is used for congruent staining, followed by the typing by immunohistochemical staining, and then accordingly, the treatment is directed depending upon the underlying type based on the immunohistochemistry as AL, AA, ATTR, and so on. Thank you very much for your kind attention. I'll be happy to answer any questions which may arise before we start the next topic. Thank you.
Thank you, sir. We have few questions here. We will discuss that.
Questions have come. Thank you, sir. It was very illustrative, and though basics were given, the updated information also you have shared with us, sir. Only one more doubt, sir, by your laboratory or histopathology opinion experience. Are there many cases of the dermatological involvement of amyloidosis of the skin, amyloidosis in the skin? The manifestation you were also told in your slide, the lichenoid features are present in some cases. So your experience, sir, any biopsy were frequently taken in such cases, and the incidence and the common causes for such cutaneous manifestation of the amyloid. If you had come across any cases, kindly ventilate on that aspect, sir.
Professor Subramaniam, cutaneous amyloidosis, first of all, is a uncommon manifestation of systemic amyloidosis. So therefore, is not common. When the dermatologist suspects cutaneous amyloidosis and submits a biopsy, we have rarely found confirmation by congruent stain. I would say, in my experience of about 40 years, we have only seen two cases of lichen amyloidosis, which presents as kind of lichenoid cutaneous lesion in a systemic amyloidosis, and we could confirm it by congophilia and conjugate staining. Because in systemic amyloidosis, most common manifestations are, they appear much earlier actually, are in the form of solid organ involvement. The manifestations would appear much earlier in those organs, like in kidney, for instance, or bowel, you know, the diarrhea, loose motion, or, you know, renal failure. Some of those manifestations will become much earlier than the cutaneous manifestations, and therefore the physician will be able to go ahead with a kidney biopsy or a rectal biopsy and have a confirmation from the lab than a dermatologist. So it is a very advanced cases where you have lichen amyloidosis, and we could you know, see it much less often than other organs. Yeah.
So suppose as you rightly told, we also have not, I also in the past 30-40 years, we have not come across any cases of biopsy sent with the feature of amyloid. Only one case some 20 years back in a lymph node deposit was there. And in your experience, what is the incidence in India, sir, as a secondary amyloidosis? Secondary amyloidosis, at least.
Well, secondary amyloidosis, oh yes, secondary amyloidosis is the only form which we are seeing day in and day out, actually. We rarely come across primary amyloid. That's settled, because looking at our population, looking at the diseases which are widely rampant, the infectious diseases or even inflammatory diseases, you know, infectious diseases like bronchiectasis or lung abscess or chronic osteomyelitis and all the chronic bronchitis, all those, and inflammatory conditions like autoimmune diseases like rheumatoid arthritis, ulcerative colitis, IBD. So all these diseases comprise the bulk of cases for us. So it's not the myeloma which we diagnose with amyloid, because we diagnose most of the amyloid, which is secondary form of the amyloid. That's settled. Yes, so is the case with hemodialysis associated amyloid. We come across that also much less often. The periarticular tissue biopsies come sometimes, but not so often, because by that time patient has either undergone a renal transplant in 10 years of dialysis, or has died during that time. So therefore, hemodialysis associated amyloid or ATTR is also much less often in our population.
So 3 more questions I have asked in the chat box, sir.
Yeah, sure.
Is there any genetic predisposition for this amyloidosis? Because there is a familial type of amyloidosis you have mentioned, familial type of amyloidosis. Is there any genes identified for patients prone for this proteolytic abnormality or the deposition of the?
See, this is the current focus of research world over, to identify susceptible cases who are genetically predisposed to develop amyloid. Because you see, most of this kind of research is taking place in the Western world, where primary amyloidosis is more common. And primary amyloidosis is a disease of longevity. The survival in those populations is much more. You know, Alzheimer's disease is common. Alzheimer's disease is associated with amyloidosis. So is the case with other, primary amyloidosis in the form of conditions like plasma cell dyscrasias. So they are doing the research to identify susceptible people or genetically predisposed individuals, but no definite genetic pattern has been identified so far. The emphasis as of now has been to reduce the proteins, the precursor proteins in the blood, you know, so that the degradation of those proteins is reduced. That's what is the current focus. And that's why chemotherapy is one of the treatment options which is being used, the chemotherapy for that purpose, to destroy those proteins before they pass on as misfolded proteins.
Yeah. Thank you, sir. Thank you, sir.
Any other questions in the chat box?
Yes,
I can find about 2 questions in the group there also. The people who have typed it. One is the stain analysis to detect cardiac amyloidosis. The stain analysis to detect cardiac amyloidosis done routinely? No, it's not done. In fact, that is possible to identify by specific stain and basically by endomyocardial biopsy, something which is not routinely done. So therefore, it's only in high-end centers where EMB, endomyocardial biopsy, is done, where they will, like only Institute of Medical Sciences has some experience on doing this. And a related question to this is that it leads to restrictive cardiomyopathy. That's because of deposition of amyloid in the interstitium of the myocardium in the left ventricle. And therefore, you have restricted cardiomyopathy development. If you look at the types of cardiomyopathy, one of them of cardiac amyloidosis is restrictive cardiomyopathy. And the last question here was drug for chemotherapy. Well, I don't know that. I'm not a physician, so I don't treat. So I would not know which drugs are used. I do know that they use chemotherapy. Which drugs they use, I wouldn't know that. I can't answer that.
And of course, with your permission, sir.
Thank you, sir.
Of course, with your permission, only one question. Since you are also a consultant in a very popular laboratory, the hematological indicators or your experience in the COVID-19 scenario as a pathologist, as a hematological indicator or any laboratory indicators proving that there will be a cytokine storming will be there, any experiences you have? Of course, it's out of the topic, but we want to hear some word from you.
Oh, see, my area of work is largely focused on to tissue lab, the histopathology and the cytopathology. So the other labs are doing those cytokine assays or the other markers which they are doing, like serum ferritin or CRP and all those, they are doing that. But they have not done analysis of all that, from what I know. I think it will take a lot of time to build up the data at national level to know what the profile of these cases. As such, we know the protocols developed by the government of India was to dispose of the bodies just after a COVID death takes place. So we are not likely to see the autopsy data in these cases because no protocol had been developed for autopsy. And therefore, we are not likely to learn from autopsies in COVID cases. But from blood markers, some data may come in coming times. That's a possibility. Can you excuse me for a moment? Somebody is pressing the bell. Sorry. Yeah, sure. Sorry.
Is there any more questions?
So that answers your query. Yeah.
No questions, sir.
I request you, sir, shall we, if no more questions in the chat box, shall we proceed for that? May I request you for the
yeah, sure.
slide seminar from your side?
If there are no more questions, there are no more questions in the question answer chat box. Shall I go on to the next one?
Yes, sir. Please, sir.
Okay.
Yes.
Because we've already exceeded the time. It stopped working. I think I'll have to re-enter.
Oh, please, sir. Please.
I'll leave and can you hear me, please?
What is that?
Okay, okay, all right. I'm sorry for this.
And I think so.
Is it okay?
Yes, sir.
Okay, thank you so much. My apologies for this interruption because there was a problem in the system or in the network. Okay, in the next about 30-40 minutes, I'll just share my experience on a few interesting cases, assortment of cases where we learned lesson and we thought others may also gain from our lessons learned. First case is a 53-year female who had a nodule in the posterior aspect of right elbow, 1.5 centimeter, and X-ray showed a soft tissue swelling, and the diagnosis suspected was of tuberculous lymphadenitis or a schwannoma by the lesion, and the lesion was excised and submitted. Now it showed a large area of pink degeneration with the granular debris in it, and this was surrounded by these pale-looking cells with light vesicular nuclei, and others were kind of spindle cells, and some appearing like lymphomononuclear cells. So these were the cells which were seen surrounding this pink area. Close-up would also show the same kind of pink area, pink material in the form of degeneration, some nuclear material, debris, and this appeared to be kind of giant cell, and the myxoid background, and some spindle cells and pale-looking cells. Another area with a similar kind of look. Here there was a large amount of this pink degenerative material, and you could find these light-colored appearance of large cells which have these vesicular appearance, some giant cell here and there, and very few lymphomononuclear cells. So this is what was the morphology which we could see. So the overall morphology did not look like that of a epithelioid cell feature, or not an epithelioid cell granuloma, and this degeneration was also not like caseation necrosis, because this was far too brightly eosinophilic. And to us, it looked like a fibrinoid material. And therefore, these cells look like the large macrophages to us, but not like epithelioid cells. And some of them, giant cells, were also not like the giant cells which you see in tuberculosis. So this is what we found in this material. And another area we showed again a brightly eosinophilic material which surrounded pale looking cells with the abundance of the macrophages and some slender giant cells, not really having multiple nuclei like you have in Langerhans or foreign body giant cells. So we wanted to know from the clinician, because on seeing this biopsy, we suspected that it could be not a nodule of the tuberculosis. It was not like a caseating epithelioid granuloma, but instead it looked like to us non-caseating and fibrous material, and therefore we went back to the clinician and tried to find out, is there any history of some autoimmune disease or some condition like that? They said there's a known case of rheumatoid arthritis who has undergone bilateral knee replacement 1 year back, and now this biopsy from the elbow has been sent, but earlier synovial tissue was submitted to us only. So we look back the previous synovial tissue. So this is what we saw in that slide again, when we saw those slides again, which were reported by us already. So this was the synovial tissue which we had received, had the lymphoid aggregates, and this in the lymphoid aggregate in the vicinity, you have degenerated material and necrotic pieces of bone, and the lymphoid aggregate surrounded by these large macrophages which are present, and the degenerated material in the synovium had shown positive staining with fibrin, that is PTH stain was positive in that. We had reported that already as rheumatoid arthritis, consistent rheumatoid arthritis, when the synovial biopsy was sent to us 1 year earlier. It's only that the clinicians many a times don't give you the prior information of what was sent earlier without a cross-reference, and therefore it becomes a kind of question mark for you. Are we dealing with the rheumatoid arthritis, but you can't make the diagnosis of rheumatoid nodule on the basis of a nodule in the elbow only, unless you have a supportive history or supportive findings, clinical findings, or biochemical or serologic findings. So this was actually a rheumatoid nodule in the elbow in a known case of rheumatoid arthritis. Now, distinction of caseous necrosis from fibrinoid necrosis, what we find is that fibrinoid necrosis is brightly eosinophilic, while caseous necrosis is more like granular cheesy material. And then the cell type of granuloma will be different. In tuberculosis, you do find epithelioid cell granuloma, which are quite characteristic, while in rheumatoid, you have macrophages admixed with some lymphocytes, and sometimes you can also find lymphoid aggregates. And rarely you may even find amyloid deposition in these lesions. The other differential diagnosis which you think of on seeing that kind of morphology like we saw in the elbow nodule is a gouty tophus, but gouty tophus, besides presence of those macrophages, will have crystalline material, which if we see it in polarizing light, will shine. So those needle-like crystals will shine in that granuloma. Granuloma annulare is another differential diagnosis which will have mucinous degeneration in the center of that granuloma, and mucinous degeneration is identified as bluish color, and it's generally in the skin, and this has Elchian blue positivity. If you suspect granuloma annulare, then you try to do a Elchian blue stain. Well, parasitic cyst is another one which will come as a differential to your mind, but then the cellular infiltrate is quite characteristic, where you will find eosinophils also admixed with it if the parasite has calcified or has incited reaction around the cyst wall. And schwannoma, neurulomoma with degeneration can also come into the differential diagnosis, but then you have to find Verroque bodies and the palisade appearance of those cells. So the catch point was that about 1/5 of the cases of the rheumatoid arthritis can develop nodules, subcutaneous nodules, or in the periarticular nodules, the periarticular locations. And therefore, it's important to correlate with the clinical history or the serologic findings. So it's important to go back to the clinicians to have the clinical history and other results of investigation, and focus on the cell type of granuloma rather than being carried away by clinicians' diagnosis of tuberculosis. So therefore, cell type of granuloma is important to characterize, and likewise, distinction of one type of necrosis from another is important, and sometimes special stains like PTH, AFP, and Elchian blue can help if you are thinking of any other differential. My second case is a 45-year male who had swelling on the dorsum of right wrist about 1.5 centimeter, has been present for about 6 months. And the possible diagnosis of this nodule on the wrist suggested by the clinician was query ganglion, query giant cell tumor of the tendon sheath, or query AV malformation. These are the usual diagnoses. You will think of a nodule on the wrist, the ganglion or giant cell tumor of tendon sheath, or AV malformation. Now, this is what was seen in this nodule, that there was a lumen lined by flattened cells, and the lumen had this kind of appearance, which looked like to us a thrombus. And thrombus, which was kind of organized, part of it was organized. And this organization had several vascular channels in it, which were in the form of papillary network. So you have a kind of intraluminal papillary formation in a thrombus in the lumen of a vessel. And these on close-up will show that these vessels also have the same kind of lining cells, that is endothelium, which are flattened cells along these, and this is part of that organized thrombus. So within the thrombus in a vessel lumen, you had these intraluminal papillary formation. Sorry. And that is the thrombus which was seen. That's the residual lumen of the thrombus, and another area to show the similar kind of papillary formation, where the core of those papillae is kind of collagenized in this area. It's been present for a long time. So therefore, hyalinization or hyalinized collagen has developed within this thrombus. And this is again another area showing part of the thrombus, part of it is organized thrombus, and organization with this papillary formation. Morphology is much better seen here in the papillary formation, where you find nice endothelial cells lining those papillary structures. So this is intravascular papillary endothelial hyperplasia, what we call as Mason's hemangioma. Now, this is exclusively intravascular lesion and lacks the necrosis. There are no bizarre cells in this and no atypical mitosis. And there is generally a residual organizing thrombus which is present in it. So these features distinguish it from an angiosarcoma. And then the epithelioid hemangioendothelioma as another differential can be distinguished by epithelioid endothelial cells in hemangioendothelioma, and those lesions are embedded in myxoid or hyalinized matrix substance. So the catch points here was the diagnosis suspecting under the scanner view, where you find residual lumen and a thrombus and part of the thrombus which is organized. I think the scanner view would help you the most in this, first of all, and then go on to, because that's what we always emphasize. Do not become a high-power pathologist, but become a low-power pathologist or a scanner view pathologist first. And therefore, visualize the section under scanner view or low power first to suspect that condition, and then go on to the higher magnification. And the high power will establish the absence of anaplasia to distinguish it from the angiosarcoma. And in doubt, you may like to do the endothelial markers like factor VIII and CD34. And these are common locations for the Mason's hemangioma, like skin, subcutaneous tissue, and extremities. My case 3 is a 49 years male who had history of pain, abdomen, anorexia, and weight loss for about 1 year. And a CT scan done raised a suspicion of carcinoma of the stomach. An endoscopic biopsy was done first and was reported outside before the patient, the biopsy came to us for review. And subsequent to review of biopsy, a partial gastrectomy was done. And during that review of biopsy, we found out that this patient was HIV positive. Now, this is what was seen in the biopsy, which was reported outside, where the enteral biopsy tissue, which showed basally placed nuclei with some stratification, but luminal border was entire. And on close-up, the stratification of the basally placed cells or nuclei showed these kind of owl-shaped large inclusions, which could be seen very well. So these inclusions were forming kind of budding into the lumina of these glands. You could see them at several places and very clearly. So on these, a diagnosis of adenocarcinoma had been made by another pathologist before it came for review, and therefore it needed a very careful confirmation after we suspected it to be CMV, and therefore we wanted a stain. So this is what we suspected on H&E morphology, and we and besides that, we also found the spore-like structures clung onto the mucosal surface, which was like cryptosporidium. And therefore, we got the antibody stain done for this, for confirmation that these are not anaplastic cells, but actually are inclusions of CMV. And we could establish it by anti-CMV antibody, that these are not anaplastic cells, but actually the CMV. And we also wanted a confirmation that there is no rise in the proliferation marker. And therefore, the proliferation marker Ki67 was localized only to the basal layers and not in the layers of cells beyond that. So the germinating cells only had Ki67, but not in those cells which had those CMV inclusions. So therefore, the diagnosis in this case was CMV pseudotumor, CMV-induced pseudotumor with the cryptosporidium infestation. Now, obviously, at this stage, we had established that this patient was HIV positive, who was presenting with abdominal pain, diarrhea, weight loss, hemorrhage, and therefore was losing weight and appetite. Now, CMV-induced pseudotumor is an uncommon condition, but it should be suspected in a case where HIV is known. And the usual presenting features are diarrhea, and many of these cases have more than one pathogen identified. In this case, we could establish CMV and cryptosporidium, but in addition, you may find other common organisms like Mycobacterium avium intracellular. And sometimes you may find other tumors associated with the HIV as well, like Kaposi's and lymphoma as well. So the catch point here, the lesson to be learned was that the CMV-induced pseudotumor as enteral mass lesion should be entertained into the differential diagnosis in HIV-positive cases, besides Kaposi's and lymphoma. And the absence of anaplasia and presence of intranuclear organisms in epithelial and endothelial cells should raise the suspicion of CMV rather than anaplasia. And therefore, in such cases, the special stains and immunohistochemistry is confirmatory. Case 4 is a 28-year-old male who had low-grade fever with evening rise of temperature for 3 months. The patient had night sweats, loss of appetite, and loss of weight. He had multiple form non-tender lymph nodes in the neck, ranging in size from 0.5 to 2 centimeter in diameter, but there was no hepatosplenomegaly. MEN2 test was negative, and patient had mild anemia, mild leukocytosis, and ESR was markedly raised. And the clinical suspicion based on these features was both lymphoma, metastasis, and tuberculosis. So first they did a FNAC of the lymph node, followed by a lymph node biopsy, because FNA raised the possibility of a condition. Now, this is from the FNA smears, the MGG stained smears, which showed an admixture of population of the small and large lymphocytes in the background, and in between there were some large cells which were binucleate cells and having some nucleoli in them. But in addition, there were also areas like this. Besides presence of these binucleate or cells with those kind of nucleoli, there were areas like this where there was presence of epithelioid cells. You can see them clearly, that there is the epithelioid cell granuloma here with the necrosis. And then on the basis of that, we gave the diagnosis suspicious of Hodgkin with caseating granulomatous inflammation, advised histopathology correlation. Because here we were suspecting two diagnoses on FNA morphology, a Hodgkin because of the presence of binucleate cells and a mixture of the population, and the presence of epithelioid cell granuloma. And therefore, we raised the suspicion here that this could be a mixed pathology. Please do a histopathology correlation. And that's what we found in the lymph node biopsy. So lymph node biopsy showed a large area of caseation necrosis underneath the capsule. But if you see in the deeper area, you can find the same kind of those big cells. You know, you can find why I've taken this picture is under 4x to show both areas. The areas showing caseation necrosis in the subcapsular tissue and the deeper areas which showed those large cells in the background of the effaced nodal architecture, which eventually turned out to be Reed-Sternberg cells, all these, if you see them closely. Now, you go to 10x and you find that there's caseation necrosis, there is epithelioid cell granulomatous inflammation, Langerhans cells, but deeper down, you're finding Reed-Sternberg cells with mixed population of cells in the background. So this was presence of both pathologies in the same lymph node seen on FNA and confirmed on histopathology. And this is again to show you both pathologies in the same field, the way you could find the caseating granulomatous inflammation and the presence of Reed-Sternberg cells with mixed population of cells in the background, and other areas which showed that appearance of the Hodgkin's disease with Reed-Sternberg cells and mixed population, a better morphology here for Reed-Sternberg cell. And Ziehl-Neelsen stain was also done and it found out to be positive. This is not a very good picture, but it was found out to be positive. So we gave the diagnosis eventually as mixed cell Hodgkin disease with coexistent tuberculous lymphadenitis. If it was only caseating granulomatous inflammation, we would have given a caseating granulomatous lymphadenitis compatible with tuberculosis. But here, Ziehl-Neelsen was positive, so therefore we could definitely say it is tuberculous lymphadenitis along with Hodgkin's disease. Now, just to show you another case which we saw some years earlier, is a 58-year, this is a corollary of this mixed pathology of the Hodgkin or lymphoma with granulomatous inflammation. Now here, 58-year male who had pain in the right leg fossa for 6 months, had constipation, right hemicolectomy was done for intestinal obstruction. And in this case, what we found was the presence of an invasive tumor. Now, this invasive tumor of adenocarcinoma with extravasated pools of mucin had elicited a lot of granulomatous inflammation in it. But this granulomatous inflammation was in the vicinity of mucinous material, and there was presence of mucinophages in the vicinity, and giant cells also had mucinous material in it. So you find that there is mucinous material because of elaboration of mucin in the invasive adenocarcinoma with presence of some giant cells and the presence of mucinophages forming a kind of granuloma here with this inflammation surrounding it. So there are giant cells here also, but a close-up will show that these are mucinophages with mucinous material, and that's the giant cell in the vicinity of a mucinous material here. So is the case here. You can find the granuloma elicited in response to elaborated mucin in mucinous adenocarcinoma. And a mucicarmine will confirm the presence of mucin inside the giant cell. So therefore, you could be very sure that this giant cell is because of the mucinous material. So there was Hodgkin with tuberculous lymphadenitis. Here, it is adenocarcinoma of the bowel with reactive granulomatous reaction or reactive granulomatous inflammation. So when do we call malignancy with tuberculosis, or is it a reactive granulomatous inflammation? It's very equivocal. Now, hematologic malignancies more often have this kind of combination. Hodgkin more than non-Hodgkin, where you can find the granulomatous reaction in the vicinity. But non-Hodgkin lymphoma can also have granulomatous reaction. Besides lymphomas, some carcinomas can also have reactive granulomatous inflammation, like the lung, colon, stomach, and breast cancers. Now, the diagnosis of this is made by the various molecular tests for tuberculosis, but then the combination of these two can occur when there is tuberculosis with malignancy, and is more commonly seen in countries where there is higher prevalence of tuberculosis. Tuberculosis complicating Hodgkin is generally more generalized and is more severe than in other forms of cancer. And the possible pathogenesis is that the cancer patients are immunodeficient, and therefore it's a form of reactivation tuberculosis in these patients who are on immunosuppressive therapy, besides the inherent disease cancer, which is which renders the individual vulnerable to infections. The reactivation of tuberculosis occurs in these patients because of impaired cell-mediated immunity. So chronic infections, therefore, increases the production of oxygen radicals, and then they cause oxidative DNA damage and produces this condition. So the catch point here is the index of suspicion has to be there, and therefore rule out non-caseating sarcoid-like granulomatous reaction in Hodgkin, which is far more common than coexistent tuberculosis. Sarcoid-like granulomatous reaction is generally non-caseating and may have fibrinoid necrosis sometimes. That is generally more common than the coexistent tuberculosis. The lipogranulomas can also be seen in the vicinity of these cases, and that can come into the differential diagnosis. Generally, they have lipid-laden histiocytes, and you need to look at the section at different levels. And if you find granulomas, the other differential would obviously be sarcoidosis, and sarcoidosis will show non-caseating granuloma with sometimes possibility of giant cells containing these inclusions like Schumann bodies, asteroid bodies. And the inflammatory bowel disease can also be associated with granulomas, especially the Crohn's disease. that also needs to be viewed in cases of carcinoma of the bowel, whether it is because of granulomatous reaction in Crohn's with carcinoma or not. The last case is a 40 years male who had a mass in the left middle ear, and this mass was adherent to the jugular bulb, and the clinical diagnosis, clinical and operative diagnosis of glomus jugulae tumor. So the head and neck surgeon excised the tumor in multiple fragments and sent it to us, which on morphology showed these kind of whorls of cells, and cells were spindle shaped. Along with that, this material was identified, which by different people in the team of resident doctors was interpreted differently. Somebody said it is a lymphangioma, somebody thought it is a hemangioma. So variety of possibilities were suggested by residents. But on close look of this, it appeared that this is a homogeneous material, and this material doesn't have any lining around it. This is not lying in the vessel, but actually it's lying in the blood. So this whole material is lying in the blood itself. While the lesion is here, this is an extraneous material which came in the surgical biopsy, carried along with the biopsy material. So that was the homogeneous pink material lying in the blood, which is hemostatic gel foam, which is used by head and neck surgeons and the neurosurgeons. So they use this gel foam as for hemostasis, but sometimes it comes to pathologies in the tissue, and so therefore it may be misinterpreted. So I brought this case basically for this, that this was a simple case of schwannoma, and this gel foam got carried along with the tissue biopsy to the lab in formalin and got into sections and would result in misinterpretation. So gel foam can come in biopsies, and not to be confused with lesions like lymphangioma, hemangioma, or parasites and so on, or foreign bodies. So pathologists need to be aware of variety of devices which are used by surgeons, and they may come in our biopsy material and need to be kept in view. The gel foam is a sponge-like material which is used for hemostasis and is used by ENT surgeons and neurosurgeons, and it expands in closed space, and if lies for a long time, it can incite fibrosis, but it's mainly used for hemostasis. So finally, the take-home message from these 5 short cases is to share our experience of lessons learned with others. So there are 2 ways of learning. One is by committing mistake, other is learning from mistakes of others. So this is also a way of learning. So learn from mistakes of others besides learning from your own mistakes. So active, interactive teaching is best method of learning more and more. So I also learned from my team members as well. So it's best to practice evidence-based pathology rather than having a overbearing kind of impression of a senior person emphasizing on others. So whatever I say is the final word. Sometimes the team members may come up with very good suggestions. They should always be considered. So I always say, either convince me or get convinced, but don't bully me. I don't bully others. So it should be evidence-based pathology. If somebody brings out an observation on the basis of microsection, you should be able to convince them that this interpretation is this way, or the other person will convince you, get convinced. So there should be no embarrassment in learning from juniors, as well is the way I have learned pathology. Lastly, before I close it, I'm happy to share with all of you that I have, along with my colleague, Ivan Damjanov, who is a very well-respected professor of Professor Emeritus in US, was chief editor of Anderson's Pathology at one point of time. Now Anderson is no more coming in the market. So along with Ivan Damjanov, I have come up with another pathology book for PG entrance exam as well as for USMLE. So it's an Indo-US project because I'm associated with the professor from US, and the way it is presented is a question answer format called Pathology Simplified, and it has question answer, short answers and two small questions with the line sketches. And there is a supplement along with the printed book, which is online, and that includes 1,200 questions. That includes MCQs, it includes clinico-pathologic vignettes, and it includes image-based questions, and all with explanation. So I'm very happy to share with you this new development. This came to me just 2 days back. I thought I'll share with you. Thank you so much for your attention, and I'll be happy to answer any queries and questions.
Thank you, sir. It was very much interesting, and though it was only 5 slides, you opened our eyes. We will keep all your suggestions, sir. All the 5 slides were very much thrilling, and that was the last 3 slides. It was very much thrilling. It is an education to us. We will also follow. We will keep those points in our memory and do the service to the humanities, sir. And I think no more questions, sir. Anything else? So now, according to the agenda, what is the next?
Thank you so much, sir, for enlightening us on amyloidosis, and even the cases were very helpful for us, sir. Thank you so much, sir. Now, a vote of thanks by Dr. C. Shashikala ma'am.
On behalf of Department of Pathology, AMCH, I convey my gratitude and thank each and everyone who participated in this session. We thank our Honorable Chairman, Mr. J. Satish Kumar. We thank our Honorable Chairman, Mr. J. Satish Kumar, and management for their support to conduct this webinar. On behalf of Annapurna Medical College and Hospital Department of Pathology, we express our gratitude in multitudes to the star speaker, Professor Dr. Harsh Mohan, for enlightening us with this brainstorming session. We thank our respected Dean, Professor Dr. P. Shanmugam, for chairing this session. We thank Medical Superintendent, Professor Dr. Mohan, Deputy Medical Superintendent, Professor Dr. Prasanna, Vice Principal, Professor Dr. Usha, and Professor Dr. Dhanashekhar, Director Academics, for their valuable presence in their busy schedule. We thank our Professor Dr. P.M. Subramaniam, sir, for constantly planning and showering us with academic fees, and also for being the backbone of the Department of Pathology. We thank all the HODs, professors, residents, CRRIs, last but not the least, our dear students who attended and benefited from this session. We thank all the faculties and students of various institutions within Tamil Nadu and also other states for their participation. I thank my own faculty and team from the Department of Pathology, Dr. Selvanayaki, HOD, Dr. Saranya, Associate Professor, Dr. Binda, Assistant Professor, Dr. Sharmila, Assistant Professor, Dr. Deepti, Assistant Professor, who are vital in conducting this session. Lastly, I extend my gratitude to the team of Information Technologies headed by Mr. Rajendran, Electrical Department, and all the non-teaching staffs for their timely presence and helping us to organize this session. Once again, we thank everyone wholeheartedly for participating.
Thank you, ma'am. Now we all stand for the national anthem.
National anthem, sir.
National.
you very much. Thanks to you all. Thank you for giving me this opportunity. Thank you all. Thank you.
I'll be in touch, sir. Before you leave USA, I'll call once. Once again, I'll convey my thanks.
Thank you so much. Thank you for giving me this opportunity. Thank you.
Bye, sir.
Thank you. Thank you all. Thank you all. Thanks to you all.